session of practical relevance in cataract surgery. And I'm Dr. Rajendra Prasad, and I have with us Professor Titial and Dr. हाँ शुरू यहीं से करते हैं अरविंद कुमार मौर्य तुम शुरू करोगे हाँ मैं कर देता हूँ ठीक है So this is going to be a kind of panel discussion session. We'll have a short video presentation and then the discussion. So I would request Dr. Arvind Kumar Maurya to come with this presentation. The first presentation is going to be there. And because till then we'll be waiting the result. Gaurav is not there. Rohit is not there. Rohit is not there. Namrata, I don't think she'll come. शुरू कर ठीक है आप ही शुरू कर दो So I think Dr. Arvind's video is not ready. Till then, we'll start with Professor Titial's presentation first. And Dr. Titial is going to talk on intraoperative zonular dialysis, what I do.
करेक्ट हो गया आ गया हाँ थैंक यू So we have some of the videos where we'll show you some challenging scenarios, and you can also contribute by we'll ask you what should be done in those cases apart from the panelists. So my area which was given to me was to look into a intraoperative when you have a general dialysis or bag dialysis. How do we manage such scenarios? So you can have bag dialysis at any stage. It can have during the nucleotomy, during the hydro procedure, during actual aspiration of a cortex, which is the I think most important risk factor, or cases with already having a dialysis or subluxation where you're trying to do a much more aspiration of cortex vigorously. Or sometimes we have seen that happens during the IL implantation or a subsequent IL rotation. You can have the dialysis happening. So I'll show you 3 scenarios and ask you what should be done at that particular stage. So this is one case. I'll be showing the video here. If you see the video carefully here. So this is a grade 3, grade 4 nucleus. I'm doing a good nucleotomy procedure. So you can see the nucleotomy being done quite effectively, completed. Now I'm doing a epicortical cushion aspiration. Just keep observing that. You can see that area of dialysis. Can you see that area of dialysis very clearly now? This particular area. Here you have the dialysis. इसमें जोरी नहीं है, so pointed में. So what should be done at this stage? Any comments from the house? People who have experience? Okay, I'll ask Dr. Rajendra Prasad to comment, sir. What should be done at this stage? Because we have a dialysis here.
All right, you can come over there.
I presume that you immediately stop the irrigation. There is a chance of, the machines have a reverse foot switch where you can, if the cortex is stuck in the irrigation aspiration port, you put it out, then come out after putting some viscoelastic inside, and then get a CTR ring ready, and then go forward.
Okay, you mean to say press the reflex
yeah,
something, and that will detach the hole?
Probably the rim of the capsule has been caught, and that's why it has pulled up the zonules. So we need to get the aspiration port free from the material inside. And then if it is not there, you can tease it out with a second instrument. And then before coming, the probe coming out, you should put a viscoelastic dispersive, and then use a CTR ring to stabilize it and then go further.
Okay, here's a point. Dr. RP, can you suggest something?
Definitely, because we'll have to wait and stop here and take out the phaco probe and then inject some viscoelastic. I think the best option would be to put a capsular hook here. So put a capsular hook, because this seems to be, it's not a the cot capsule, it's a the cortex which is adhered to the capsular fornix. It's
Yes.
not a cot capsular edge. It's an adherence of this. So that's why, because when you are pulling the cortex away, the capsular fornix is coming along with this. So the best in
Absolutely.
this situation is to put the iris.
I
So,
think
sorry,
good observation. And this scenario normally happens if your initial, hydrodissection was not good. If you do a good cortical cleaving hydrodissection, this will never happen because the cortex will be loose and aspiration will be easier. So every step has the, subsequent step making easier or harder. So this is what has happened. So what I'll be doing here, I'll not remove my handpiece abruptly. I'll remove my second instrument and inject the dispersive viscoelastic to fill the bag from here. It's not working from here, so that it will fill the entire bag with the dispersive viscoelastic. The bag will get inflated. Then you can aspirate, take out the handpiece or do a bimanual aspiration. See how effectively you can manage the bag. Let's see what I have done in this particular case. So that is what I'm doing. I'm putting a dispersive viscoelastic here. I'm not removed my handpiece here. After that, with the filled with the dispersive viscoelastic, I'm trying to remove the capsule. As Dr. Rajendra Prasad rightly said, it was not the capsule I was thinking. It was this particular thing was attached. So this bimanual apparatus is very, very handy here. So I'm injecting the dispersive viscoelastic before I come out. Then again, now cohesive viscoelastic in that area. I didn't put the hook here. I thought this hardly 2 clock hours of dialysis. The CTR is being put here. Subsequently, the CTR has to go little away from there. So I'll put here. It's then stable here. The idea is not to show the dialysis. Idea here is to understand the initial procedure of hydro procedure is going to make a huge difference in a subsequent entire rotational nucleus and aspiration of epicortex and managing the bag effectively. CTR is one very important necessity in your operating table. You may require any time the CTR. You may not require, but may require. So it should always be standby in your cataract trolley as such. So this is one more video, similar type of case. So I'm doing a complete aspirin. I've removed the cortex here. All the cortex are effectively removed. Now I'll be injecting a viscoelastic to inject the IOL. IOL is done. Now see, everything is all right, but sometimes you may be little vigorous. I'm trying to push my IOL to remove the posterior fibers. But see here, I've got a last bag dialysis here because I pushed the IOL like this. So this is a stage again. You may have to do similar. I'll re-inject the dispersive viscoelastic anteriorly and posteriorly also, and inject the CTR. So you have to inject CTR in such a way it doesn't get entangled to a haptic here. So for that you have to inject viscoelastic little in the back so that this IOL gets lifted up. Then put a CTR here. I'll put CTR just underneath the IOL and rotate in the same manner. It will get fixed up nicely here. Here again, the learning here is when you are have a viscoelastic in the anterior chamber, viscoelastic in the back, and IOL is there. Whenever you're manipulating the IOL, it should be a little gentle so that it doesn't disrupt the anatomy of capsular bag in these cases. So this is another case, high myopic patient. A really nice capsular axis, complete good hydrodissection. I'm doing a little trench to create the hold and subsequent chop here. You'll see during my subsequent chopping here, I'll try to rotate. You can see the bag here now during rotation. Entire bag is loose here. So I can't rotate because bag is absolutely fragile in at this case. You can see that movement of a bag. So this entire bag is loose. So this is a time I thought I would do a fixation of a capsular axis. Dr. Rajendra Prasad, what you would have done? Should I put a CTR at this stage, or should I put a hooks to manage the capsular bag integrity?
Putting CTR at this stage would be difficult. That is one thing, because the nucleus is so big and so hard.
Mm-hmm.
And the best would be to hold the capsule with the capsular hooks.
Yeah.
In this situation.
Any different ideas? I think that is what I also thought. CTR putting in this mobile bag, and the entire nucleus is bulky. It will be difficult. It may not be able to support the bag integrity. It's always better to make a incision at that time. Put hooks, and subsequently you can manage. I made a 6 entries of thing, so that you have a hexagonal fixation. So I have 3, 4, 5, 6. So you can have a nice hold, and subsequently you can complete the phaco in this particular case here. This is the last piece I'm taking out, epicortex will be removed. And make sure at this time also, it is always important to maintain the integrity of capsular bag. Now I'm doing a bimanual aspiration. That is always better in those cases where you have a loose bag, as well as you have put a iris hooks, because some of the fibers may be entangled with the iris hooks. Always complete the aspiration before you put a CTR, because after putting CTR, sometimes aspiration can be difficult. In that process, we might damage further granules here. So I'm removing some of the bag, inject the cohesive viscoelastic to maintain the bag in all around. Enlarge the incision now. I'm putting a 3-piece lens. This is a high myopic patient. As such, require the expand series of IOL. So I'm putting this IOL in the bag. The other option could have been I would have put the lens in the bag, and this being a larger diameter lens would have stretched the capsular bag. But I thought the bag is loose. In the long run, this bag may not be sustainable for an IOL. It might drop down in the next 5 to 10 years. The idea here is to put the lens in the sulcus. So haptics will be supporting the sulcus. And to center the optics, I've got a capture of this particular optics into the rexus. So this is the lens going to sulcus now. This is the trailing edge. I'll get the lens. Now I'll get into the inside the capsular bag, push this lens inside, and get a capsular, you can say anterior capture with happening this lens. The two things I did. One is capsular bag was fixed during my nucleotomy procedure, so that further damage doesn't occur. And second was to place the IOL on the sulcus. The haptics are resting there, and for getting good centration, optic was captured into anterior capsular axis. Because I had enlarged the incision here, I put one suture, because if you enlarge the incision, you could put the lens, not wound assisted, into the over the rexus margin. Okay, thank you. And any comments, Dr. Rajendra Prasad?
Okay, thank you very much, Professor Tyal, and the beautiful videos we have seen, and how to manage the dialysis of the capsule, and especially the last case where the whole capsular bag was so loose and it's completely mobile. These are the situation we get with a very hard cataract. That is one, like where you have the zonular weakness, although you do not have the zonular dialysis at all, but the zonules are quite weak and quite stressed out zonules. You get the movement of the bag. And then, of course, as Professor Tyal has shown, it's high myopia. You get a very big and mobile bag. And these situation, like, you have to be really careful while operating, because your phaco movement, like the phaco probe or any forces you are putting, may directly hit the capsule, because the capsule is flexible, and it keep fluctuating anteriorly in these situations because the bag is big and loose. So you have to keep your phaco parameters low, set your vacuum and the aspiration rate you have to keep it low so that you do not get too much of fluctuation, because otherwise you may hit the posterior capsule. And the another situation, like if the zonular dialysis is another problem which we may come across in this situation. And then putting the IOL, as Professor Tial has shown, like he has preferred to use the 3-piece IOL. And 3-piece IOL on the capsule or in the sulcus is one way. But then what about putting the single-piece IOL within the bag?
Well, that would have been an option in these cases, but what happens when you have this bag so loose, and ultimately because of there must be some disease process. Maybe this is a myopic patient, there will be a myopic degeneration happening, and the bag will get contracted in subsequently, and the chances of a future dislocation is also there, like pseudo exfoliation cases. So I thought, why to compromise there? Always better to put on the sulcus, because even a bag gets little fibrous, it will not make a difference in this particular case.
Very right. Yeah. So any question?
Yes. If you see the hooks, capsular hooks are, people who use them, they have to be expert, because they are bulky and quite big, and sometimes putting those hooks are so difficult, you can damage further. Iris hooks are, they have a smaller area of, you can say, management, easy to put, easily manageable. Only thing, you make sure they are new hooks, they don't have a sharp edge. Don't use the very, very long reuse hooks, because they don't have a strength. Otherwise, iris hooks are very nicely can be placed. Only thing, you have to make sure iris hooks are placed little, posteriorly in that posterior limbal incision, so that they are parallel to iris plane. They don't tend the iris. That mistake we do, make a little anterior incision, then it tends, and the chances of tear happen because you have a lot of flow going on during phaco.
And these days, the iris hooks, we are getting the blunt tip iris hooks also, because earlier we used to get very sharp tip iris hooks, you must have seen. But the last few years, we are getting the blunt tip, and it's very safe to put these iris hooks. Yes, you wanted to say something?
Mike, please.
Mike, yeah. Good.
In the last case where the zonal weakness was all 360 degrees and the whole complex was shaking, what I normally do is that there's something known as bimanual rotation in hydrodissection. So that the whole force is applied on the horizontal level, and the capsular zonules are not involved when you are doing a bimanual rotation in after hydrodissection. After hydrodissection, if you do with a single hand, you tend to pull the zonules wherever you are pushing. But here it is push and pull technique, where it is rotated centrally without involvement of the capsule and the zonules. So it helps in maintaining the integrity of the complex.
Yeah, right. Good point. So now,
sir, one point, sir.
Yes.
And sir told me we have to put that incision or insertion of the for behind the limbus, because not to the limbus, as much as possible while putting that iris retractor. And usually what I am doing is, I don't know how much for the iris is inserted. So limbus or just anterior to the limbus will put the iris hook. And how many millimeter back we can put, sir, practically in the limbus? How much millimeter back we can start inserting that iris retractor? Point of entry.
Point of?
Entry of.
Entry. Point of entry, as Professor has already said, like you keep little on the posterior limbus. Don't keep anteriorly.
No, in limbus itself, posterior limbus.
Posterior limbus.
Not to go beyond 2-3 millimeter, you should not go.
No. Posterior limbus. Too far away also won't be good.
Oh.
Little posterior.
Little posterior, that's all. Yes, correct. See everybody.
Too far away, then you won't be able to put also properly, because then iris will come into the surface. Actually.
Thank you, sir.
Thank you. So now we'll go ahead with Professor Arvind Kumar Maurya, and he's going to talk on rock hard cataract, what technique he's going to use, prefer. So Professor Arvind is, he's at Bangalore.
Hyderabad,
one of the very innovative person, and has been very active in most of the conferences you must have seen, and hundreds of award winner. So, Professor.
Thank you so very much, sir, for your kind words. and good afternoon, everyone. The rock hard cataracts are always a challenge for all of us because there are a lot of complications associated when we are doing phaco in such cases like the endothelia burn or the compressive forces which are acting, so leading to the high ergonomics, the high phaco forces we have to use. So it is always a challenge, wound burn and whatnot. So it is a technique developed by Dr. Rajendra Prasad sir. It's a terminal chop, which is different from the vertical and the horizontal chop. Volume, please. Display.
Terminator, chopper used in terminal chop technique for full thickness nuclear segmentation in mature hard cataract. The authors have no financial interest in the subject matter of this film. Mature hard cataracts are virtually all nucleus. The nucleus is packed with cemented lamellae of hardened and compressed cortical nuclear fiber layers, making them physically identical to the solid hard rocks, stronger in compression but weaker in tensile strength. The greatest challenge is in breaking them down because it is a real difficult to segment these hardened and compressed cortical nuclear fiber layers with the routine phaco forces and chopping techniques. There are several techniques which we all have been practicing for the last 20 years, but when it comes to these mature hard cataracts, nothing works, and quite often we do not achieve full thickness nuclear segmentation. The reason for that is, with the current surgical technique, the mechanics of segmentation is undertaken deep at the bulky hard center nucleus with the stressful high intensity compressive forces. But according to the mechanical rock excavation systems and Griffith theory of brittle fracture, it's always difficult to crush, incise, skull and segment these hard rocks with compressive forces, but relatively easier to crack and break with inside-out dispersive mechanical forces. Cracking and breaking is still easier if the mechanical forces are applied at the open edge or naturally weak point in the form of micro cracks, notches, grooves or depression on the surface of these hard materials. To be effective, specially designed tools, wedges and feathers or pick is placed into a drilled hole, groove or natural crack. Then with a very simple maneuvering of driving the wedges between the feathers or tapping the pointed tip of pick heads into the crack forces them against the sides of the hole, causes the rock to crack and split in tension. Crack automatically traverses through the entire rock, simply breaking such a huge solid hard rock into two complete segments. Terminal chop, a newly introduced surgical technique, utilizes principle of secondary rock breakage system with stress concentration to break these unbreakable hard nuclei. In this technique, similar to cracking and breaking these solid hard rocks, a unique inside-out dispersive mechanical force is created to initiate a full-thickness nuclear crack at the weakest, soft and thin equator, which simply traverses through the entire nucleus, breaking it into two complete pieces. Mechanics of terminal chop initiates a tensile fracture in a more direct manner from the equator parallel to the nuclear surface, highly efficient with least crushing, least manipulation and minimal use of phaco forces. Unlike in vertical chopping and horizontal chopping, utilizing crushing compressive forces with high stress to segment these hard nuclei. In the unique mechanics of terminal chop, chopper plays an important role as critical instrument maneuvers to crack the nucleus is performed by the chopper along with the phaco probe. The chopper used in terminal chop, a well-acclaimed recently introduced new surgical technique by Rajendra Prasad, is named as Terminator. Terminator is a specially designed blunt olive tip chopper to safely hook, hold, stabilize and then initiate a crack at the equator of the nucleus. The mode of action of Terminator is similar to drag tool, generating stress at the sides of the initial groove in the direction of equator on the other side, parallel to the nuclear surface to create tensile fracture. Terminator consists of a round knurled handle which is similar for all types and a 60-degree angled distal shaft with a tip. Overall length of Terminator is 114 mm and length of the shaft is 12 mm. The tip is approximately 1.5 millimeter in length and angled at 80 degrees in relation to the remaining distal portion. The inner surface of the tip is flat, blunt wedge edge angled 60 degrees to the axis to create a nick and crack at the periphery of the nucleus adjacent to the phacoprobe and to prevent sideways slippage of the tip. Vertically, there are two grooves next to the wedge inner surface intended to engage and achieve firm grip of the nucleus for cracking and lateral separation while preventing vertical shift of the nucleus. To achieve perfect dynamics of terminator, the chopper used in terminal chop technique, the following steps are taken. First, we need to create a large central capsular axis with an intended 5.5 to 6 mm in diameter. Then a short, shallow, narrow central trench is created, sufficient to fit the phaco-tip to achieve a proper plane of depth in the nucleus. Then using the hyperpulse or burst mode with high vacuum settings, the phaco-tip is engaged at the distal end of the trench and impaled into the superficial plane of the nucleus, keeping the tip directed towards the equator parallel to the pupillary plane to achieve firm grip at the periphery within the equator of the nucleus. While nucleus is firmly held in position with the phaco-tip, equator of the nucleus is then slightly drawn within the capsulotomy edge. Terminator is then very simply passed around the lens equator to hook and engage the full thickness nucleus. Chopper is then simply drawn through the open edge just within the equator of the nucleus, initiating a full thickness crack adjacent to the phaco-tip. Chopper then takes a lateral position within the initial crack adjacent to the phaco-tip without making any horizontal excursion. Initiate 90 degrees laterally directed vector force, breaking the entire nucleus into two complete segments. Same procedure is repeated on the heminuclei, making multiple fragments depending upon the hardness of the nucleus. Each free lens fragment is then drawn by the phaco-probe and emulsified. Terminal chop has several advantages over the techniques currently used to ensure less endothelial cell loss and less post-operative inflammation, leading to a faster recovery and maximal visual rehabilitation. Mechanics of nuclear segmentation is very simple, swift, safe, and 100% effective with least manipulation, least phaco forces, and minimal energy consumption. To conclude, principle of mechanical rock excavation with the drag pick system could be safely used to break these solid, mature hard cataracts. Terminator, the chopper used in terminal chop technique, holds all the properties of drag pick to generate optimum tensile force to initiate crack at the open edge equator of the nucleus. Terminator is highly efficient, least traumatic, giving minimal stress on the zonules and posterior capsule while giving firm hold of the nucleus along with the phaco-probe to complete the mechanics of the nuclear segmentation. Complete nuclear segmentation achieved with terminal chop propagate a quick and safe nuclear fragment emulsification with least manipulation and minimal use of phaco energy, resulting in exceedingly satisfactory post-operative results. Thank you for being with Terminator, the chopper used in terminal chop technique in this video presentation.
So we have done over more than 5,000 cases using this new technique developed by Dr. Rajendra Prasad sir. And we have done the world's first clinical trial between the terminal chop technique versus the stop and chop versus the direct chop. And the results are very encouraging in terms of least phaco energy used, in terms of least endothelial cell loss, and least cumulative dissipation of energy while using the terminal chop technique.
Thank you, Arvind. It was a very nice demonstration of how to manage supra hard cataract, because those are the challenging situations. Just one query, Arvind. As far as rexis size is concerned, what will be the guide size when we are using this terminal chop technique, where because you are holding and you are pulling the entire nucleus for a cutting? So what should be the ideal rexis size? If people say hard cataract should do a large rexis.
Yeah, it's a very pertinent question. So these kind of hard cataract, they require a larger rexis. So I prefer between 5.75 to 6 millimeter. because we need a large axis. We need to go to the weak point, that is the equator. So we need a larger axis.
What about doing a little oval rexis, which is, people from, Punjab has propagated in a posterior polar cataract. They do a little oval, rexis. They say it improves their nucleus management, though I never thought about that. But if you are doing a little oval rexis in these cases of your axis of chopping, then things again may be much more convenient,
Yeah, we have tried in few cases and it works very well.
Okay.
Yeah.
Yeah, Dr. Rajendra Prasad.
Yeah, oval rexis is one of the beautiful concept, and if you are keeping the oval rexis radial to your main incision, like where you are entering the phaco probe, if it is radial to that, then it gives you a very, very good control. Like you have a good area of even if not the terminal chop, any other chop, like you'll have a good area for manipulation. So especially in terminal chop, because if you have a oval rexis radial to that, then you can easily hook it. Your hooking would be much easier and the cracking would become much better.
Yeah. Dr. Rajendra Prasad, you have faced some situation where, this terminal chop could not be done, or it could not separate the piece at all. Now, how to go about those cases? You do a rotate and try from other area or something like that?
Yeah, definitely, because as we do the horizontal chop or vertical chop, like if you do not get any first chop, then you just rotate the nucleus, go on the other side, try on the other side, and you can keep rotating like where you get. But most of the time you get, because generally you get with the first chop only, but if you don't get, but you'll definitely get the chop second or third.
Okay, thank you. Any questions from the house? Yeah, please come.
Hard cataract, I would say that if it goes well, it goes well. If it doesn't go well, then whatever innovations that you can do on table is important. So for me, the first thing is that rotation should be very clear. It should be very free. And as you said, if you cannot chop the nucleus into half, so what I do is that I take it to the center, all sides. So the central part may not be separated, but each quadrant, then I cut a sliver. Each quadrant is then cut into 3. So this sliver becomes a very narrow piece of pizza, you just pull it and then you swipe from behind. So what happens that the central part gets lifted up, and this sliver that comes out, once 2 slivers come out, then the entire nucleus will get lifted up from the center after debulking, and you need not worry about separating the entire nucleus into 2, and then you can easily eat.
Okay, yeah. That good technique, especially if you're doing a chop technique and you can't separate the central plate, and you do a multiple peripheral chops, and ultimately if you tackle the central area, all the chops open up itself and you can take piece by piece. Thank you, Arvind, for taking up this.
Thank you very much.
Thank you so very much, sir, for giving me the opportunity.
Thank you.
Thank you.
So I will now request Professor Titial to come out with his second presentation, and as he has to go for the OPL, so we'll take up his second talk also, and he's going to talk on I got a PCR, then what to do.
Okay, I'll show you 2 videos how we manage the intraop posterior capsular dialysis happening in these cases. You can see this is a typical posterior polar cataract, and how to handle these patients, and especially if you open the posterior capsule to begin with. So this is a typical onion peel appearance, this large center, almost 3.5 to 4 millimeter disc. And if you see the intraop OCT picture also, difficult to appreciate where is the posterior capsule. So this is a moth-eaten appearance. So I'll do a delineation, which is classically told. Delineation has to be done in these patients. So just see, I'm doing a delineation on one side. Just observe this particular part. I'm showing it again. So this is what happens in a high-risk case of posterior. Can you see that? I'll show it again now. Injector fluid. See the flutter happening in the posterior part. The posterior capsule are given way at that stage only. So in those cases, how do we handle these cases? Because now you have an open posterior capsule, but we have done a hydrodelineation. So you will be having an epicortical cushion to support that open area. So it is must that you don't rotate the nucleus or epinuclear complex at this stage and avoid the opening getting larger and drop happening in these cases. So what I'll say there is importance of making a small chop area and taking out the piece and allowing the fluid to get into the your hydrodelineated area, making nucleus free. Without rotation you can manage. So what I'll do here, you can see I'm doing one chop here. So this piece will be taken off us. We are not rotating the nucleus here, and each piece will be taken layer by layer, and the entire piece has come out now. The nucleus has been taken out. This is the epicortex I'm trying to remove now. So you can see gently I'm taking out epicortex here. Entire bulk has come out. Now at this stage, you can see that there's a PCR already visible here. This is a tear area, but it is well maintained. If your irrigation well maintained, it will not open up. That this again you saw in the previous case, I'm injecting dispersive viscoelastic to maintain the space. Then go for a aspiration by these cases. So this is a stage you have the large opening in the posterior capsule, which you can see it is going like this. And the vitreous is not there. I've maintained the entire area with the dispersive viscoelastic. Now, what should be the IOL implantation choice? Dr. Arvind, will you go for a 3-piece or you'll still go with a single-piece IOL here?
Because this particular case, you have a complete radial tear in the posterior capsule. And you have to be very careful because the 3-piece IOL would be the best. You can still put into the capsular bag. But only thing is your haptics have to be perpendicular to the tear. It should not be radial to the tear. It should be perpendicular, like it should on the opposite axis of the tear.
Okay, I think that's the one option we have, because I thought my opening is, it is there, but it is well stable, which normally happens in the posterior polar cataract unless you have a very, vigorous aspiration of fluid hydrating the vitreous face. So once you tamponade the vitreous face with the dispersive viscoelastic, the vitreous normally remains down. So I'm injecting the single piece IOL only. For that, I'll not inject wound assisted because that might, damage my area here. I enlarge the axis so that my nozzle of injector goes inside. I'll open the lens over the, anterior capsular axis margin and gently tuck the haptics behind without causing too much of a damage. And as rightly pointed out by Dr. Rajendra Prasad, I'll be putting lens like this. So that's the one option here. I'll fill the chamber with a dispersive viscoelastic. Now see how inside I'm there. My lens will open over, over the iris in fact, so that I don't damage the, now gently tuck the optic inside and the haptic inside. So the both things have gone inside, shift it towards the center. The little distortion has occurred in the posterior axis, but it is still intact. And this is because it's not a toric lens, so I'm not worried. This is not a multifocal lens, I'm not worried as such. So it's quite stable now. I'll form the chamber and quite stable. Leave some dispersive viscoelastic there to tamponade the vitreous face. Nothing will happen. But if you want to be very sure, sometimes you might inject the triamcinolone in the anterior chamber. See if the vitreous is there. You can do a removal of vitreous also. Any comments, Arvind?
Sir, do you prefer doing optic capture in such cases?
This is a case because it is a simple spherical IOL. I thought I can keep it anywhere. It will remain stable. I'll show the next video, then that will be much more answerable to you. This is the patient, again, posterior polar, not posterior polar, but I've done a femtosecond laser device. I'll open the, all the chops here, then remove the entire nucleus. I'm doing a bimanual aspiration of cortex. So I left little bit of cortex because bimanual with the handpiece here, and I could not aspirate this part. I thought this cortex I'll aspirate subsequently and inject the IOL, and this was a trifocal Acrosop lens. So you can see I'm injecting the Helon now, which is sodium hyaluronate, nice rexus, injecting the trifocal lens. Very nicely it has gone inside. At this stage now I'll do an aspiration. I thought I'll just pull this cortex here. And as soon as I pull this cortex, entire capsule opened up. You can see the capsule opened from here to here. The entire half capsule is not there. And this is a toric, trifocal lens now. What to do? So I'm injecting dispersive viscoelastic just underneath the IOL margin, and from here also, so that it will tamponade. The idea here is I can't remove this lens. The idea here is to make a reverse optic capture of this particular IOL and tamponading the vitreous face with the dispersive viscoelastic. This is Biscoot from Alcon. No financial interest in this, but that's the one good viscoelastic here. Then I'll shift this optic anterior now. Just shift to this area and keep the cushion of viscoelastic there so the vitreous face doesn't come out. Again, now I'll go to other side. So the other side has to be lifted up. Inject the dispersive viscoelastic underneath the IOL margin. That will again form, then lift it up. You can see then the lens is quite stable here. Then I'll do a bimanual procedure to lift both optics sides up together. This is one side. Now I'll go from this side also and lift this up. So you can see this quadrangle shape has come up because haptic is behind and optic is upwards. Maintain the chamber, and you can see the lens is nicely oriented, and this is the picture here. So this is how sometimes you can safeguard your this thing. This is the picture at the end of surgery. You can see a quadrangle shape. This is underneath the rexus margin. Optics are above the rexus margin. So sometimes if you don't have a vitreous coming up anteriorly, you can just save your day with the reverse optic capture also. Okay. I think I have the I don't have the pictures now. I did have the 1 year follow-up also. It's stable lens. And any comment what will happen to a post-op refractive error in this patient, Dr. Rajendra Prasad?
See, because now you have done the reverse optic capture. The first of all, we have to see the centering. It has to be, because since it's a trifocal IOL, in trifocal IOL, your centering is very, very important. And then the lens is going to be positioned little anteriorly. So you are going to have overcorrection. So you have to be ready for that. And but in a trifocal IOL, a little bit of overcorrection is always better, because patient will have a better near vision. May have a little compromise of the distance vision, but he'll definitely have a better near vision.
Absolutely true. And this patient already had a trifocal in other eye. This was second eye. And this was, I could achieve not very well center, but you can see these are, the Perkins images in the central area, and axis is also nicely oriented. Luckily, when this lens opened up, the lens was in a proper axis. If lens would have opened like this rotation per se would have damaged the remaining posterior capsule and would have created more problem for this patient. The patient did have a little 0.5 myopia and a post-op period, and but he had a good near intermediate vision. Despite that, he was quite comfortable. But because this lens opened inside the bag, then subsequently posterior capsule opened up. But if you have a posterior capsule opening beforehand and you're trying to do a reverse optic capture, then you should change your IOL power and go for another lens which has a slightly less power than in the bag power in your case, because this is like a lens kept in a sulcus. Okay, thank you. We can go to the next.
Thank you very much, Professor Tityal, for the beautiful videos we have seen today. And any comment or any question from anyone for Professor Tityal? Okay.
Now I would like to invite the Terminator, Dr. Rajendra Prasad, and he will be. Okay. And he will be presenting on IOL gone wrong. How do I manage surgical pulse?
So good evening, and chairpersons and dear friends. My topic is I'm going to talk on a few case series on IOL gone wrong and the pearls of management. It's not coming to the. No, no, but it has to come this. Yeah, bring it to this full. I need the full presentation. No, it's full screen. It's not coming full screen. नहीं है वो आ जाएगा प्रेजेंटर व्यू में नहीं आ रहा है नहीं प्रेजेंटर भी इसमें करो ना फुल स्क्रीन में फुल स्क्रीन क्यों नहीं चल रहा है ये है ना ये चल रहा था मेरे उसमें दोबारा लगा के देखो इसमें प्रेजेंटेशन व्यू भी नहीं आ रहा ना ये आ रहा है ना प्रेजेंटेशन व्यू भी तो नहीं आ रहा तो चलो पहले वीडियो लगा दो ठीक है मैं कर लूँगा So in cataract surgery, because having your IOL well positioned, well centered is the most important thing, and for the patient satisfaction. And many times we are not sure because we go into the ill-judged landing of the IOL into the capsular bag. So this is the first case, and as you can see, the IOL, one of the haptic is stuck at the capsular edge. The one haptic is gone inside, so what to do in this situation? Very simple manipulation of this IOL can bring out, and what I'm trying to do is just trying to rotate the IOL, and once you rotate, free this haptic from the capsular bag, like especially because this was all adhered, the vent ahead, the vent and the IOL was finally implanted into the capsular bag. So this second situation, as you can see, this is the trifocal IOL, what Professor Titel was showing just now, because now this IOL is completely decentered and dislocated. One of the haptic is in the bag, other haptic probably there seems to be a capsular tear or something, or dialysis of the capsule. So what I'm trying to do is, because a very simple method, either you have to do the exchange or you can reposition this IOL into the bag or over the bag. So I have taken out the haptic out of the bag and tried to bring it to the center, and then I finally found that the IOL has taken its position because the capsular bag is fibrous, so you have a support behind, and this is how I tried to bring it to the center and position this IOL at the center of the pupil, and you can see the IOL is well centered, and this patient post-op gained good vision, because although the refraction was not very accurate, but yes, patient was quite satisfied with -1 diopter for the distance.
Dr.
Another
Rajendra
case,
Dr. Rajendra Prasad, the previous case,
yeah,
how much was the duration of post-op, both the cases?
this was almost 2 to 3 months.
So this shows that even after 2-3 months, he could open the bag and lens was placed in the bag in these cases. The duration is also very, very important. Sometimes the fibrosis can be much bigger. In plate haptic lenses, you still can open up, but if you have a non-plate haptic lenses where you saw the previous case where they have an open loop haptic, optic haptic junction gets fibrous with the capsule access margin, and it's very difficult to open sometimes.
But this particular case, because this is a plate haptic, so plate haptic generally won't fibrous that much as you have these C lobes and other lobes, and you can very simply slip it out of the capsular bag. So that is what the first case, and this is the second case, which. So the third case, and as you can see, the IOL is completely dislocated again. It's almost sinking into the vitreous cavity. So what should I do in this particular situation? So I'll just ask Professor Tityal what to do in this situation. I'll just show you a little remind it, and this is the IOL.
Yeah. Again, this is again an open loop haptic case. And seems to be a haptic outside the bag, in this case, or one haptic maybe inside. That is how it is decentered. And again, I would like to dissect out the rhexis margin. You can see the fibrosis seen at around 3 o'clock or 4 o'clock area. Then we can just dissect out the viscoelastic, open the bag if possible. The fibrous area should be managed, which is at around 9:30 o'clock. And if you can open that, then lens can be nicely rotated inside the bag.
Yeah. So as you can see, one of the haptic is in the bag and the other haptic is almost sinking through the capsular tear what you have in the posterior capsule. So what I tried to do, oh my God, what happened? So what I did, as you can see here, like I just trying to dissect with the viscoelastic first, and then I'm trying to bring this haptic anteriorly and just hook it and then dial it, and then taking it back into the position under the iris. And once I got it, and then I'm taking it on the anterior capsule now. So I got the whole IOL. The second haptic automatically came out of the torn capsule, and now this IOL, as you can see, well settled on the anterior capsule. So this is what we can do, because instead of exchange. Now this is another case. The patient underwent RK a few years back, and then underwent cataract surgery also. And this post-op, the refraction was quite inaccurate, and the patient was absolutely unhappy. So we had to do the exchange in this particular case. And the exchanging the IOL in post RK surgery is not that easy, because you have certain issues. But what I tried to do in this particular case, brought the IOL, hook the haptic, bring it on the anterior capsule, and then bring the another haptic over the anterior surface of the iris. And then you have to just hook out one of the haptic, because you want to be sure, like the IOL has to be stable within the anterior chamber for when you cut the IOL, it should not flip, because if you are holding one of the haptic out, then you'll have a much stable positioning of the IOL. And then once you cut it, after cutting it, you have to use frequently viscoelastic to protect the endothelium in this situation. And then I am trying to pull and dial technique, because you just pull out one of the haptic and then you dial, because your IOL is cut now into two. And this is how you can bring out the IOL. Once the IOL is out, then you can replace it with an accurate power of the IOL, and this patient actually post-operatively gained very good vision without any refractive error. So the intersection is very important, because when you are entering, now this is the another case, you can see the IOL is completely opaque. Now the only way out in this particular situation was to explant this IOL and change it with another IOL. So again, created the main incision, and as you can see, you have to use frequently the viscoelastic. What I'm trying to do is bringing out one of the haptic, but in this particular case, what you could see is like what I've seen, there was a posterior capsular defect also, like there was a rupture underneath the IOL, and this was this area where this haptic is there, and still I'm trying to bring it out of the capsular bag, and I could do it. And then again, the same technique, you pull out one of the haptic, and you can see the posterior capsular defect here. There's a huge defect here. And then this time I'm holding the IOL with the another forceps and then cutting it into two. So always better to give a cut on the IOL, almost 2/3 of the IOL, and then again with the dial and pull out technique, so which is the simplest technique to explant an IOL. And this is the IOL which has come out, a completely opaque IOL. And then went ahead with the partial anterior vitrectomy through that capsular defect area. Now I'm putting the IOL because now, as you can see, the IOL, implanting the IOL was the most difficult part in this particular case. But still, I tried to put this IOL into the bag. So as you can see, that the leading haptic I just inserted into the bag, and then the next haptic also went into the bag. And finally, this IOL settled very well within the bag, because although you had a big capsular defect here, but the anterior capsule as well as the fornices were intact. So the IOL went into the bag properly, and this is how the post-op looked up, and this patient had a beautiful vision. So the safe landing is very important, because the IOL has to land up in the capsular bag properly, and this is you have to similarly, like when you are flying, you have to select your airlines properly, because the airlines which is going to land up properly.
Beautifully managed. Just one question, Dr. Rajendra Prasad. You showed two exchange of IOLs. One was a normal IOL, and other was an opaque IOL. Yeah. Is there a difference in the two IOLs when you're cutting and removing them?
No, there was no difference in the cutting.
Because sometimes these opaque IOLs are a little harder to cut compared to your standard IOLs. So you have to be a little more careful. Like you nicely held the IOL and cut. That got your balance and cutting the opaque IOL. While the previous IOL you didn't hold it, you could still cut it.
Yeah, because this second IOL, because there was a capsular defect, so I was trying much safe, like so that it doesn't flip inside and increase the defect which is already there in the capsular bag.
But beautifully shown that getting one haptic out and cutting and then rotating the one by one, an entire IOL comes out. Very beautiful technique, and people should practice that, because we do see a lot of opaque IOLs in future also, because so many millions of hydrophilic lenses have been put in the eye.
Yeah.
Yes, we have a question.
Yes, Professor, there was this post-RK patient in whom you had explanted the IOL from the bag because there was a refractive surprise probably. Why didn't you go in for a sulcoflex or some lens like that and correct the error? Instead of taking the whole lens out and causing so much trauma, we could have just gone in for a sulcoflex IOL or post pseudophakic correction complementary IOL, as they would like.
Yeah, there are many options actually, because you can go with the sulcoflex also, but then sulcoflex is not that safe also, because you have to be sure like your bag size is good, and your anterior chamber depth is good. So all these parameters have to be seen with the sulcoflex. Yeah, it's important.
Yes.
So
why I asked this was because it is any day far more less traumatic than excising that IOL and bringing it out.
Sulcoflex, if you go for a proper sulcoflex from Reina, it's very costly affair. And now we have the Indian company doing these pseudophakic lenses.
Yes.
That can be tried. I have tried a few patients, but for that you need to have a good stable IOL. As well as the sulcus should be free, and the space should be there.
In this particular case, it was quite stable. Yeah. That's why I asked this question.
Yeah, you have options also.
Yeah, you have option, yeah, definitely, because so I thought in this particular case this would be a better option.
And another thing, psychologically, that patient has already undergone RK, which means from the very beginning, that patient has been very, very adamant about being spectacle free. So in such case, I mean, that's the psychological background of the patient.
You have to, change the psychology of these RK patients. What I do, all RK patients, I make them sit into my, ray tracing technology. I do aberrometry analysis, tell them your cornea is totally aberrated. I show them first, then do a surgery, because they think they are normal, they could see better with the RK. Now you'll see better with the cataract surgery also.
True.
So we have to diagnose them properly, show them your cornea has 16 scars. See the picture here, optical zone is hardly 3 millimeter, and your aberration profile is this. So they understand they may not get a good vision, and I can't put trifocal lens in your eye. I'll put a simple monofocal lens, which will give you a better option. So they do understand. We have to break the psychology in these patients. Post LASIK, yes, still, if the cornea is good, you can still give them a good vision post LASIK, post SMILE patient.
True. Thank you, Professor.
Yeah, post RK actually, because your cornea is completely distorted, and secondly, like your power calculation is not so accurate most of the time. This particular patient landed up with almost +5 diopter post-operatively, and then we had to do the complete recalculation and all. Then
The very calculation is a challenge.
yeah,
in
calculation is
addition
very
to
well.
the
We used the ASCRS calculation site, and then actually we did calculation with the other like Barrett also and ASCRS and few more calculators also, and we took out the largest size, the largest power, and added over that 2.5 diopter. Then this patient had a -0.5 diopter post-operatively with just hardly 0.75 cylinder.
True, sir. I think from 2025 AIOS, you'll have to have a separate session for handling cataract patients who have undergone refractive surgeries.
Yes.
Yeah, that's
Because
right.
all of those fellows who underwent refractive surgeries in 2000 to 2005
True.
have started developing cataract now.
True, that's good.
Thank you.
That's which, we're going to have more and more patients, post-refractory surgery in future. Because, all young patients have undergone either LASIK, SMILE. Fortunately, RK patient will decrease, but these patients are going to come. And some of the patients would have gone, presbyopic, LASIK, presbyopic, and they are going to be more difficult because you're totally aberrated the cornea in these cases. And going to be very difficult. Like we had a Camara's implant for a presbyopia, and these patients had a tough time undergoing cataract surgery also. So it's a challenge. So, just to complete, we had a one session on a flex also. Dr. Mahipal could not come. So femtosecond laser application in cataract surgery is a assistive tool. It's not a complete surgery. That we have to make patient understand is assistance to the routine phaco surgery. Then you can go ahead with the normal surgery for these patients also. There are certain situations where femtosecond laser may have advantage. One of them is a wide cataract with intumescence. Second is a posterior polar cataract, and third is a subluxated cataract. Fourth is a patient who desires femtosecond laser. There you should do it if they have no contraindication. Any person who says, I want to get a femtosecond laser done, yes, why not? If you have a system with you, do it, because it's going to give us advantage of your capsulotomy, incision, and fragmentation also. So this is what femtosecond application gives you a nice anterior capsular picture, as well as it has an OCT attachment, which can tell you the corneal profile, AC depth, the bulge in the anterior capsule. You can plan the depth of nuclear fragmentation and its configuration. And it also tells you what is there in the posterior part also. You can pick up the posterior polar cataract. You can pick up the open posterior capsule also in these cases. In wide cataracts, the advantage is more on a capsulotomy, not on the nucleotomy, because nucleus energy will not reach there, so you may have to do manual surgery. It is only the capsulotomy where you benefit. And whatever happens, the tear is not going to extend in the periphery because everything is happening in the closed chamber. So the pressure will get released. But the chances of tear going to periphery is minimal during the laser application. So see, this patient is a femtosecond we are doing intumescent wide cataract. So I plan for a fragmentation because that's not going to be effective. This is the planning for a application here. Now I'm doing here, you can see the application here. You'll see this explosion of a fluid coming when you actually make a puncture. The laser makes a multiple punctures onto the anterior capsule, and some area the fluid will come out in a significant area. So there is a cut. This area you may have a little addition because the capsule gets flattened and application laser may not be appropriate in these cases. So nucleotomy is now completed. This is the incision being done, side port incision. Now we'll shift the patient to main OR. Always stain the anterior capsule. So this was the area of explosion. So we'll have open capsule. Here you may have additions. So I would be doing a similar procedure as you do for capsular access. Rotate your hand. So these are one attachment here, one attachment here. So take a forceps and just tear it off. So you should be little gentle. You can do with a needle cystitome also. There was a one attachment there. And this is one area, I'll just tear it off, one attachment. The idea to show here is you can manage raised interlenticular pressure with femtosecond laser also, and do a nice capsulotomy and subsequently do a emulsification as you do for routine cases. This is the relatively softer cataract which you see in some of the white cataracts. Some of the white cataracts who would have a totally Brunenses nucleus also sometimes. So this is how you manage. This is another patient. I'll show you a similar patient here. Again, you see this area of OCT. It has a lot of fluid pockets, and as soon as you make a laser opening, again the blast will happen. This blast happen in two areas here. So here in these cases you'll have a skip area in these cases also. So I'll do again a staining here. You can see this is the area I was worried about. We had a opening here or opening here. I'll do a same rhexis opening in these cases and safeguard the rhexis tear going to periphery. So we have compared white cataracts with manual surgery rhexis and the capsulotomy in these cases. The outcomes are almost similar, manual versus femtosecond laser. But femtosecond laser, we had a more circular capsular rhexis and the capsulotomy, and chances of tear extension during procedure in both the cases are comparable. We had one case in series of 80 cases in each group. Let me show one in a posterior polar cataract. As I said, this is one area. You can see the entire posterior pole of in the OCT. So this patient didn't have the open posterior capsule, but we could initiate the procedure here. So this is a technique described by us where we do a capsulotomy, the posterior polar cataract of around 4.9 millimeter size. Then we're doing this as a hybrid technique. We'll do 3 layers of nucleus, you can say delineation, femto delineation, and 8 chops. So this is 3 rings of delineation and chop pattern being done. Idea here is to have 3 blocks of a nucleus, and you can take out 1 block at a time without rotation of entire nucleus or a posterior epicortical cushion. So I'll shift this patient to OR now. You'll see the technique here. We can translate into the manual surgery also. So I'm removing the free floating capsulotomy here. So I have a multiple chops here. Then I won't do a hydro dissection delineation at all. I'll open this chop. You can see the bubbles will escape. And once the bubbles escape, the pressure goes down and fluid seeps into the space here. So this is the first block in the center. The second opening I'm doing again. Now I'll take primary block. I'll remove this block now. This is called block by block disassembly of nucleus fragmentations. You just use a second instrument, pull this piece to a center, remove that. There's no disturbance of the peripheral part of lens and epicortex. So this is how advantageous femtosecond can be. You can do entire manipulation without a rotation of the segment of epicortical cushion here. Now I'll go to epicortical cushion and remove one by one. By the time the fluid would have seeped into a space and gives you an internal hydrodissection also and complete the surgery. So these are 2 areas where femtosecond laser may be advantageous and gives you a nice assessment of your case and complete the surgeries subsequently also. And this is the application in subluxury cataract here. You can see this is a very difficult case. And if you see here, classically, the OCT tells you have a little decentered appearance because this is nearer to the pupil iris and this is away. So this is the area of subluxation, and this is the bolus of vitreous in the anterior chamber. So despite bolus of vitreous, I can do a capsulotomy in this particular case. It's not contraindication that you have a vitreous, you can't do a capsulotomy. So I do a little posterior, as somebody was asking. This is how the posterior it is, a little bleeding coming out. Stain the capsule here and do a, okay, what's gone wrong? Then put the hooks and put a tamsulanol to see the vitreous there and do a proper vitrectomy. Then take out pieces. You don't require to do a hydro procedure here again. You can remove each piece as you saw in the posterior polar cataract and remove the epicortex subsequently area. You can see the capsulotomy is very nicely, can handle the pressure of hooks also. It's not that laser capsulotomies are very, very weak. They're as strong as an axis. And here again, after completion, before I remove my handpiece, I'll inject the, viscoelastic there, put CTR and complete the surgery. So these are three important areas I consider femtosecond laser advantageous. Apart from that, you can see the OCT picture also of your case, and the morphology of situation difficulties in posterior polar and in wide cataracts and subluxular cataract also. After completion surgery, I've done the vitreous management. Subsequently, also you might think you have done a complete vitrectomy. There may be one tag there. So after completion, also use the tamsunolone, stain the entire area, and cut that, and you have a very nice pupil subsequently also. Thank you. If any question, we can take subsequently.
Thank you very much, Dr. Titial, for the beautiful videos. Any question or any comment from the house? Yes.
What is the effect of femto on the vitreous?
You mean to say cases like this where you had a vitreous in antechamber? In this particular case, you saw that if the vitreous is there, when you're applying the laser, there was sort of a jelly formation, because the vitreous will not have a bubbles which you normally see in a clear anterior chamber where the aqueous is there. Here, no bubbles were there, jelly formation was there. That indicated you are hitting the vitreous. So this may have a traction happening sometimes in the periphery. So you should be little careful in a post-op period, and you should do a proper analysis. I normally do a first day indirect in all these cases, do a posterior segment OCT, and follow up these patients regularly in a few months, and give them two tips. If you see a drop in vision, you have a flashes and floaters, immediately rush to hospital, because that may be a signal for something going wrong. So that's a very important part. Whenever you have a vitreous and you do a vitrectomy, vitreous management, the post-op care has to be very, very meticulously done.
Yeah. True.
Shall we conclude?
Thank you very much, and we'll close this session now here. Our time is over. Thank you for being here with all of us, and good evening, and
enjoy your gala dinner.
Yeah.
Thank you for being with us here.